Welcome back to another episode of Concentrating on Chromatography. PH, thanks so much for joining us today. I really appreciate it.
Thank you, David, for having me. It's a pleasure to be a part of the podcast.
And Candy, thanks so much for co-hosting with me today.
Yeah, of course. I'm excited.
So, PH, we were connected by some friends of mine in the space, Peter Voska and Kate Peralt more. And I understand that with them and also Dwight Stoll, you co-organized the multidimensional chromatography workshop. And one thing that's really exciting about that event to me is that it is a uniquely free scientific event, which there aren't enough of. Why is it so important to you and the other organizers to keep the barrier to entry so low? And how does that open access philosophy really fuel some of the speed of improvement that you see in the space?
So I think the fact that the MDCW is free is really part of his DNA. So the workshop was created by Eric Reiner at the Ministry of Environment in Canada, and he really wanted to spread out a technique that he see could have an impact but needed support to grow and mature to be a usable tool. So for the 10th edition, since he was retiring, he transferred the workshop to us and basically say, make it grow, bring your touch, but keep it free and affordable. And at that time, for me, I was still a postdoc when I was creating that. So I was like, oh, yes, something free. Let's make it free. And I think it was a bit naive because we jump in and say, yeah, we don't need the registration money. We'll make it work. So we make it work. And after you are just in the train saying, okay, it needs to stay free because it's really important to us. And know that you are writing a paper, submitting a grant, they ask you your vision about open science. And so you can have anything like AI generated that say how much it's important to you, but still you have a paywall for the paper, you have registration fee that are to the roof when you go for an event, not counting like the price of traveling that it's also increasing. So to be honest, for us, it became a statement of, okay, if we want to make it open and available to anyone, they need to be able to just push the door and enter the conference and interact with anyone in the room. Networking and connecting should not be limited to people that already has the funding, because this is what you need to acquire funding in research. So it's also a good opportunity for industry where usually they have only the budget for a few people to travel. So it's usually the same people that make it the job to travel around and connect with people. And there they can send a lab tech that can learn about why it's important, like some of the aspect of the work. Or he can also learn that basically like his skills are really unique to what he's doing. So for us, it's how you can have really different people connecting to each other is because it's free to attend.
Yeah, it's super exciting, and it's certainly a event I hope to check out in the next year when it next occurs. And I thought it made sense to lead with how we connected, but I'd also love to hear about your background in general and how you became interested in the space.
So I started in GC GC in 2011 during my master thesis, where basically I had the chance to meet with Jeff Faucon, who I'm still working with now. And he had this, at that time, like new instrument commercially available, like GCG CMS system, and he wanted to do forensic application. So he put out this master thesis research topic about let's identify the composition of the smell of death, so the smell of decomposing bodies, using advanced analytical technique. And like I grew up with CSI TV show and I was like, this is super cool. I can use my chemistry background to do something that is related to a personal interest of mine. So it's how I started to work on the topic, really focus on the analytical technology because my background it's really analytical chemist and I always had a focus on the technology. And it's how everything started. That's how I met Dr. Kathleen Perot, that we are now like still colleagues and co-organizer of the workshop. And at the end of my PhD, I was like, okay, forensic is great, but I could feel that we were reaching a limit because there is no dedicated funding in Europe for that. So it's always been like a side project, like difficult to support. So I transitioned to biomedical application because I was like, okay, all the what I learned about like the microbiology, the metabolic process ongoing in decomposing body, I can transfer that to disease and metabolic pathway. So I started to connect with the university hospital, seeing where my knowledge in small molecule characterization can be directly implemented to some of the clinical study that they have been created. And this is how we started to do some metabolomics, some exhale breath analysis, and like testing different like project, and through different collaboration, we ended up focusing on chronic inflammation.
I'm smiling because you used my go-to reference. I graduated from undergrad in 2010, and my school had a forensic science major. And I swear 90% of those people told me how they were inspired by the CSIs and all of those shows. It really did contribute to a whole group of people really being interested in that career path.
Yeah, that's how I got my undergrad researcher too, is like she was in the biology lab doing forensics research and she was like, I need to know how to do this. And I was like, technically, as an analytical chemist, you can do a lot more, but you can still study it. So that's how I got her to be and she be my undergrad, and it was amazing. So it's a really cool story.
Could you paint a picture, PH, of how untargeted screening of small molecules transformed our approach to personalized medicine compared to traditional methods?
So I think this is something that emerged like through technology. Like again, I'm really technologically focused, but like at one point we started to have instrumentation that allow us to see more. And I think as a scientist, like if you see that there is a potential somewhere, you naturally want to exploit it. So you were like, okay, for example, like I can have this 12 fatty acid that everyone is monitoring, but with my GC GCMS, I can see 55 other fatty acids. So I can give you the answer for the 12, but let's have a look to all the other one that we can analyze. And doing that, it's where you can get a molecular fingerprint or sequencing if we do the parallel with DNA with really the uniqueness of each individuals. So we can have like, for example, glucose level that can be the marker of diabetes, and it's universal across all people with diabetes. But if I, on the top of that, monitor like inflammatory markers and treatment response marker, I can say, okay, why I have like more difficulties to control my diabetes than other people. And to, achieve this small granulosity of phenotyping a person to a unique individuals, you need multiple markers. So that's how I think non-targeted screening has emerged, because people were saying, okay, if I get more information, maybe I can make like more subtle differentiation where everyone is becoming really unique and has its really own metabolism markers.
Are you creating a unique metabolite profiles for different disorders? Or are you guys just focusing specifically on certain diseases?
For now, we are really focused. So mostly chronic lung inflammation. And in that framework, like mostly asthma, it's because also like there is a danger to being too diversified. So, you know, sometimes when you are an analytical lab, you say, oh, I can do exhale breath analysis from asthma patient and try to see impact of treatment. And you build up a proof of concept study with a decent population and you prove that something is there. And after, like, you get excited, you go to a conference, you present it, and someone say, oh, I'm working on gastrointestinal disease. It's also inflammation. You can maybe do something. I say, yes, sure. Send me serum, small study, proof of concept, and I move on. So it's really important to do that. But over the time that I was establishing my research group, I realized that we had all these bricks that were like around us, and you never go up because you develop a method, you adjust the method, and you move to another topic. And because we found a good team of collaborators in the respiratory clinic here in Liège, we're like, okay, we are always selling the fact that we want to have an impact on patient life. And we started to go for this goal. So we say, okay, we need to do non-targeted screening. There is something there. We can increase the patient population and confirm this signature, and it works. Can we see a modification of this signature when we use specific treatment? And we went there. And so now we are really building up on the whole study that we have done for the last 6 years to really reach a point where we can say, okay, now we have a tool that we can implement in the clinic or even better at home at the patient side that can really help them to adjust treatment, guide hospitalization, give read back to the clinician when there is a peak of pollen or a peak of air pollution. So we narrow down the number of area of research to make sure that we go the long distance. And it's interesting because it's why I sometimes tell to people, is say, when you do that at one point, you reach some boring step. When you need to do the exact same thing with another extra 200 patients, yeah, no one wants to really give you money for that because, hey, you already proved the concept, so do something else. But we are like, yes, but we want to deliver something. And so in academic research, you have also to convince people. You have to convince yourself that you need to do the due diligence of validating everything. And so it's a really interesting process to say, okay, I want to really reach the promise that I've done when I wrote this program saying we will truly impact patient life.
That's amazing. I absolutely love that approach.
And one of the main messages from your presentation was we need to fight the breath proof of concept paradigm. For an unfamiliar audience, what does that mean in basic terms? And how does it bring us closer to true personalized medicine?
So it relates to what I just explained. It's sometimes when you have the technology, you want to evaluate all the area where it can have an impact. And that's really exciting. But at the end of the day, you get all these small study published where you have a small cohort because it's a proof of concept. You didn't validate the annotation of your biomarkers because it's a proof of concept. You didn't check like all the demographic information because it's a proof of concept. So being the one that lead the way in proof of concept, it's also becoming a good excuse to take some shortcuts in the development. And when you did this proof of concept, like again, you don't build up on the proof of concept. And so basically after when you arrive in the field and you say, oh, let's see what we can do with breath analysis in clinic, you see all this proof of concept that kind of playing against the goal, because if you do a stronger study and you contradict the proof of concept, which can happen, like it's science, sometimes people say, yeah, this study has been there for 5 years and no one is contradicted. And I say, yeah, but no one really challenged it. And again, it's a discussion that you are like, guys, they did 10 versus 10 patient. I'm coming with 500. I think there is no discussion at all. Like, why are we sitting there and arguing about that? And so for me, I think that there is really, again, the need to say, okay, if you have a true research objective that you want to really impact, you need to bring in the technology, the analytical knowledge, but you need to go the extra miles. You need to really prove that it will impact and that just not, oh, there is something there that maybe in the future someone else or me will pick it up and try to get something out of it.
And in that context, it does make sense that breath analysis has faced a lot of skepticism, I suppose.
Yeah, I think people went a bit too fast in like they went like against the first marketing rules. When I was taking like some management classes, they always say like under promise, over delivery, and this is the key. And in science, they push us to over promise in grant, in presentation, and we always under deliver because basically it's impossible to deliver with the amount of money that we finally get. So that just creates frustration because you go to clinician, and when you start to work with patient medical staff, you have an impact. So you can say, oh, I just need an extra tube of serum, or I just need a breath sample. It just takes 5 minutes or 10 minutes, but you impact people that are already overwhelmed with information, with procedures. So we need to be non-invasive to the medical staff. When I say that we do non-invasive analysis, for me, I try to also be non-invasive for the staff because they do an amazing job. So when they've been approached by 50 people asking them for samples that went nowhere, it's just a waste of the time, just for us to check boxes on grants reports. So for me, I say, okay, no, when we need to go there and we convince them, we need to prove them that there is something, or be honest and say, okay, the hypothesis was probably like not suited. It's not the result that we expect. What should we do? But at least we try to provide a return on the investment that they've done by collecting the sample and the information. And now we have to break this perspective where they say, yes, I did this proof of concept study on breast. It was like challenging, complicated. It never worked. They were always complaining that the sample were not done properly. And so now we are rebuilding the trust in the method by saying, okay, this is a well-designed study that proves something. We are not at the final stage here, but at least every time we deliver something saying, this is not working, this is working, let's continue this way. And I think that we will come back to that, but it's a problem for breast analysis and a lot of omics related study where we see, I see 3,000 features. And we are analytical chemists, so we are educated to say, okay, it's a features, we need to clean up the noise, we need to annotate them, we need to quantify or semi-quantify them. But for the clinician, they're like, okay, I give you a sample, you have like 3,000, and they directly go like from features to compounds. They want the list, they want the exact concentration, they want the metabolic pathway. So it's also, okay, my method is huge analytical power, but let's make it in a good use and make sure that we do a good use of the samples and provide an adequate answer. We don't promise something that we will not deliver.
So I do a lot of liquid chromatography, mass spectrometry, and I haven't delved into GC GC at all. And a lot of that is because I was trying to take GC methods and put them onto the LC. So in untargeted metabolomics, the annotation rate is really low for LC stuff. Are you guys having low annotation rates too? Because if I get 3,000 metabolites, maybe can annotate like 10% of them if I'm lucky. So is that the same rate for GC or is it different?
I think this is one of the big advantages of GC. We are higher than that. And it's just because, again, it comes back to the technology. So like in GC, we have a separation mechanism that is mostly driven by boiling point. Even if you change the stationary phase, the boiling point will always be a criteria. You will never elute your C14 before your C4. That's impossible in GC. So we have this for us that it's easier to normalize the separation. And on the analyzing side with the mass spec, we use mostly electron ionization. So we have access to huge database where we have 500, 800K compounds that are present in the library that we can use. And in LC, it's difficult. You have like positive, negative modes. Some metabolite will go one way or the other. You need a library on both sides. If you change ion source or mass spec provider, it will affect the fragmentation. So it's much more difficult to build your reference system. We do 2D GC. So on the top of this advantages of the GC, we create an image with 2 retention dimensions that is structure. So based on where you are located on the image, I know that you are a polar or semi-polar compound, that your carbon number is more like close to C10 or close to C20. So based on all this orthogonal information, we can get much more confident in the annotation that we reach at the end. And we have also small molecules because they need to be volatile or semi-volatile. So when I get accurate mass on the top of all of that, the number of potential candidates is low because I know that if I have something that is C55, that's probably not coming from my GC. So with all these parameters that make that GC has limitation in range of molecule they can analyze, but we can annotate much more inside that range.
That's awesome.
In your presentation, PH, you shared some pretty staggering statistics on how many people, including my co-host, are affected by asthma. How do you think this non-invasive approach, breath printing, can potentially radically change those numbers in terms of, you mentioned how there's the trial and error burden for patients. I'd love to hear more about that.
So the first thing to know with asthma, so asthma is huge and it's increasing for different reasons, lifestyle, air pollution, climate change, like all the main impacts on health are also linked to chronic disease such as asthma. So that's why it's so many people are affected. The problem also with asthma, it's we speak about asthma like it was a single disease, but it's a really complex lung condition where you have different type of phenotype. Different phenotype means that you have different immune response depending on the type of asthma that you have. If you have eosinophilic asthma, that's maybe start in the younger age. You can have neutrophilic asthma that could be environmentally induced or just coming with genetic, but that started later in life. So you need first to diagnose asthma, for which now, like in developed country, they have process for that, it's okay. But after they need to start to put you in the good type of asthma, because every type of asthma will come with its own treatment. And like asthma treatment when you have severe asthma, that can be like inhaled corticosteroids. So it's treatment that are highly efficient, but they have secondary effect. So for now, the method to put people in the good phenotype, it's really empirical because they need to balance so many clinical factors that it's complicated. So we are not trying to replace respiratory clinician. We try to provide them a new tools, saying with the molecular composition of breath, we can maybe give you more information about what it's happening in the lung, and you can relate that to a specific type of asthma. And that's also how we started with asthma, because in asthma, they use hexane as a marker of one type of asthma, eosinophilic asthma. So we say, okay, if we produce inorganic gas like nitrogen oxide, that probably means that there are other like secondary metabolites linked to inflammatory mechanism that are coming out in the breath, and that we can use it for really like having a fingerprinting of the different type of asthma.
And is it fair to say that the dream scenario involves a patient being able to walk into a clinic and breathe into a device where they can have their medication adjusted?
To be honest, I would even dream higher than that, and they should not even have to come to the clinic. Like when you see what you do with diabetes, they have now the chip on the arm that is just like a stickers. It's connected to the smartphone. They receive an alert like, toot, like your glucose is high or low, like adjust, or it's directly connected to an insulin pump that is doing everything. And basically they can live a normal life with the technology supporting them. This is where we should go. We should have someone that's wake up, you have a small system like on your smartphone, you just blow on your smartphone and they say, oh, you are terrific today. Let's go for a run or go outside and enjoy your day. Or you will wake up, you will blow on the machine. They will say, oh, okay, you seem that your inflammation is high. The forecast said that there will be no wind, really high ozone contamination in the city. Maybe it's the barge pollen season, and this with all this multi-factor decision, they say maybe it's time to homework and stay the window closed just to avoid any risk. Or if you have to go outside, don't make sure you don't forget your medication. So it's really to make sure that they have tools that they can forget about almost, and that is taking care of monitoring this disease, because As for diabetes, you don't cure asthma. You manage it for your entire life. But there will not be a day that say, oh, I don't have asthma anymore. It's done. So maybe you will have worse or better period in your life for asthma, depending on where you live. But you will need to take asthma into account every single day anyway.
That would be amazing for all asthmatics to just be like, I have this little like cheat sheet to make sure that I'm able to be my maximum productivity. I love that you tied that back to the earlier question where you wanted to really develop your technology to be able to go further than just, hey, we did this cool thing. We're mapping metabolites that are in lungs and we're able to diagnose you. But to take it the step further like that is pretty awesome.
Thank you.
Would you be able to talk about how the labs looked at VOCs, volatile organic compounds, released under stress, and how that's factored into your work?
Yeah, that's always complicated. Like stress, infections, like all of the side effects that we know affect metabolism, like they influence and they are hard to take into account because how you define it. So we have some really cool stuff like cooking up, like we all have now these like smartwatches that at the end of your day, they say, oh, it's been a kind of a relaxing day, or it was pretty intense or a stressful day. And they also link your activity with your like different type of factor that they follow up, like oxygen level, like earth rate, like anything that basically is able to read, and they model that. So we could try to go into this and say, okay, you have this breath detector that is with you, but because anyway, your watch, your phone is collecting so much information, we could take everything into account. And I think this is really where personalized medicine is going. It's like, I will not like just with volatile molecule find a solution to monitor asthma. I will not like just monitoring like air quality improve really the patient life. But maybe combining all this like emerging technology and studies, this is where we can power up like AI for really positive use, saying this is really intricate data that we need to figure out. And so maybe there we can build like classification model or prediction model that really, again, impacts the situation where the patient can have a good indication of what could happen during the day.
Yeah, and it's probably no surprise to either of you that during a lot of these discussions, either machine learning or AI always comes up. And I suppose one of my big takeaways from my introduction to AI in the clinical space with the protein folding case study is the ability for these systems to see patterns that even the best data scientists can't see on their own. So there's certainly a lot of promise there just with applying those techniques to area where they've never been applied before.
Yeah, I actually have a question. I work with Peter Dorstein, and he's associated with a lot of the GNPS, the Global Natural Product Social Molecular Networking. And one of the things that they've been able to do with all of their platforms is the ability to add tags the way that Google does. So you have like your short searches and stuff like that that you can add in, and Google can fill it in. Is that similar to what's happening with the GC libraries for searching for results and stuff, where like you guys are linking things? And having AI fill in the blanks a little bit for when you're doing a like upload your spectrums and be like, where's my network going?
That's, I think, the drawback of GC. It's because it has been like easier to generate libraries. For now, you have mostly commercial library coming from the NIST of Wiley. And so they are less reactive to the need of the field. So like currently there is no such tags because they say, no, it's not built in. And as long as there is no an interest for them to provide this option, they don't really want to change something that has been running for years. So we have a bit more inertia on the change. But yeah, I'm a big fan of what they are doing with the GNPS approach. And I think that One of the issues that we have also with breath analysis is our molecules are so small that usually we don't have the metabolic pathway that go down to this molecule. We stop like at n+1, n+2, or n+3. So with the approach, it's, I think, a really elegant way to try to bridge the gap, saying, okay, there are studies like maybe in serum or other lung fluids using LC-MS. They go down to the mechanism until there. I'm here with breath analysis, like, let's find a way to predict which molecule in between could link these two into a single metabolic pathway. So I think this is something that is not deeply explored yet, but I can really see the need of bridging metabolic pathway identify with from larger molecules and from really small molecule and try to get the full story there on where these molecules are coming from.
We started the conversation talking about your involvement in the MDCW, the multidimensional chromatography workshop, and along with your research, you have a deep commitment to promoting chromatography in higher education. When you look at how separation science in general terms is traditionally taught, where do you think there could be improvements? Is there anything you think is missing in terms of preparing people for the next generation of becoming clinical researchers?
Yeah, I think separation science, but I would even extend that to analytical chemistry. It's underrepresented in education curriculum that are not like specific for chemists. And I think this is like sometimes a bit problematic when you need transversal research, because that means that people, they see the in papers like they've been doing LCMS or they've been doing GCMS, but they don't really know what's the subtlety behind that. So not everyone need to be able to solve the Van Dimter equation in different conditions and do like really fundamental chromatography. But they should be aware about what the technique can do and mostly what they cannot do. I still receive like requests to review a paper where people are doing breath analysis and they are like doing a massive effort to make it compatible with the LC system because they see that LC is the most used technique in metabolomics. So they say, okay, I have like something coming from the human body, so it's biological. When I look on ChatGPT, I saw that it's mostly LCMS, so I have to put the breath in the LCMS. And okay, it can make sense for you when you look it that way, but on my side, it makes absolutely no sense. So I think there is a need to make sure that people understand what are the tools that are coming into the clinic, into the lab, especially that this tool, the LCMS, the GCMS, the direct MS, the ion mobility, they are making the way into the clinic. So that means that the number of people between the sample and the result coming out of the mass spec is reducing because the systems are becoming autonomous. When you see the rise of robotics, the robustness that you can have now, like you can just put the plasma tubes on an autosampler, come back the second day, and you have the fatty acid profile that has been done by a robot. And that's great to reach like high throughput. But that means that since you will have maybe less expert like present or dedicated to an instrument, you will need to have awareness at multiple levels that say, okay, this sample need to go into this technique. So I need to make sure that it stay in the fridge, it stay on ice during transfer, that I have a proper QA/QC. Everyone is their own actor of the analytical workflow. So I think this is really where we have to pay attention, is to make sure that if these tools become routines, they need to be part of the education curriculum like any routine tools.
Do you think that would be routine education for like the medical staff, or do you think this would be more so like routine education for getting scientists into the hospital system?
I think it's a bit of both. I think they will need to have dedicated scientists in the clinics and closer to the clinical staff. But it's also mean that maybe even when they request tests, they will have to say, oh, I need some microbio work through the MALDI, I need the peptide profile through the LC, and they will have to be able to identify what does it means to make sure that the information that they are providing are not like just duplicates of the same information by two different techniques, or that they are taking like the good samples. So that doesn't mean that they will have to explain everything or have the knowledge in the head. I just think that the system need to take that into account. Maybe the way that they will check for what do you want from your blood work will need to be adapted to that. So I don't have a perfect solution. I'm just like throwing out like issue for others to solve, but I think that we need to increase that. And I also need like, even for scientists in general, like chromatography has been a bit overlooked. People are saying, yeah, soon we don't need chromatography. With ion mobility, everything will be done in 2 seconds. Like with my 1 million resolution on my mass spec, I don't need separation. And maybe we are going there. When I see the speed of development of the system, this is impressive. But as of today, when I go to a pharma company or any like food company, the lab is full with LC and GC. So we still need people that will run this instrument correctly, be able to develop a method and deliver qualitative results. So I think that we don't need to underestimate what chromatography is doing, even if it's only routines. We still need people to run and manage the lab of routine analysis.
That was definitely one of the big areas of focus at the American Society of Mass Spec conference last month, in terms of, with ion mobility, how important is chromatography moving forward. But at least on the podcast, when I put people on the spot, they back off and say, oh no, chromatography is still very important. What advice would you have for early career scientists? Certainly the core audience of this podcast is undergraduate researchers. Do you have any advice for those students in chemistry or medical students who are interested in analytical chemistry, chromatography, but they're interested in healthcare challenges?
Yeah, for me, I understand the excitement for this topic because I think this is like translational research. So sometimes you feel that you are really connected to fundamental research like technology or data processing, but you still want to see where it's going. So that's also the interest of clinically oriented research. But if I have an advice, it's you have to stay curious about what you are doing and engage with that. So for me, when I started to work in asthma, I knew asthma like everyone, but I didn't really understand the challenge of asthma. And it's really exciting to be like discussing with the clinician, because sometimes you say, oh, I still remember my first study. I say, oh, I have all this like phenotype of asthma that you gave me in the population, and I can make sure that I can differentiate like eosinophilic from neutrophilic and neutrophilic from polygranulocytic. And I had all my graph and my PowerPoint animation, and everything was like super smooth. And I can still see my collaborator. We are still working together. And I say, pH is great, but I don't need that. Like, I never ask myself these questions. So all your graphs are great, and I'm glad it's working, but we don't need that because this is not the question that we ask. And there, I still really see myself there because I realize that we have been making the assumption that we can ask any question that we want to the chemical information that were in the sample, but we need to be relevant. So it's by getting curious in engaging with people with other specialty like clinical staff or OMDs that you can say, okay, what you want in fact is to say, okay, I want to identify neutrophilic from an entire asthma population. And I want to identify this treatment response in this global population, because this is what they cannot do in the clinic. So now the process of developing the study is totally different. I go there with my notebook, I sit and I say, okay, you are speaking about treatment management, but what is the treatment? What is doing? What's the timeline of the response to the treatment? And so I learn a lot about how they do in the clinic. And after together we say, okay, you have the patient the first day of treatment, they come back like every 2 months for a year, and after we evaluate, so that means that we have so many time points, maybe we will skip one because it's too much samples, but you really have to engage and educate yourself. And to be honest, I always say my student, like, okay, guys, when I see what they are doing in the clinic, they have the research and the rest. So we need to be the one that bridge our chemical information to what they do. So we need to learn. So, and I stay in academia. So basically, I'm still, for me, a student. I can still sit in one class of physiology and be really excited about all these new things that I'm learning. And so it's really important to make the bridge and be the one saying, okay, I've seen like this fundamental paper on the inflammation mechanism in asthma. I think that it can be correlated to that. Like, which type of sample do you think we can collect to answer this question? And they say, oh, yes, but if you do that, we have this new treatment like under clinical trial. We should also take sample on that. But you have also always to make sense and make sure that what you do as an objective, and the objective is to impact positively what's happening in the clinic.
And in closing, was there anything we missed today, PH, in terms of introducing your work to a broader audience?
No, I think we went over pretty like my main area of research and my main interest in making sure that everyone can access this through the MDCW. So thanks a lot for having this discussion, because as you see, I'm always excited to speak about like what is happening in the lab.
Scientists always want to share the knowledge that we have, eh?
Sure.
That's great. I'm so happy to hear that you enjoyed the conversation. Thanks so much for your time today, PH, and Candy as well. And I look forward to sharing this with the audience. So thanks so much.
Thank you very much.